and any men who have had sex with men, and gender non-conforming or non-binary individuals who have had multiple sexual partners in the past 14 days. Vaccine is also being prioritized for people with HIV or other conditions that contribute to a weakened immune system. People who are eligible for JYNNEOS, a healthcare provider or local health department can assist with connecting them to a monkeypox vaccinator. In addition to vaccination, DHS encourages individuals to take precautions to prevent disease. Monkeypox does not spread easily from person to person. Most cases that have been investigated by public health in Wisconsin and nationally were transmitted through close skin-to-skin contact during sex. However, it's still important for all Wisconsinites to be aware of the signs and symptoms of monkeypox because anyone can get the disease by having close contact with someone with monkeypox. For example, by having direct contact with the skin lesions or body fluids from an infected person, through sharing items such as bedding or clothing of an infected person, or through potentially prolonged exposure to an infected person's respiratory secretions. People who may have been exposed to monkeypox should contact their healthcare professional if they're feeling sick or notice any new unexplained rashes, and we encourage clinicians in the field to obtain testing through the increasing number of laboratories that are able to do testing for monkeypox. Now, I'll be happy to answer any questions, and I again thank you for your attention to this important issue.
Thank you. And before I take your questions, a reminder that for audio quality, please stay on mute until it is time to ask your question. And in the interest of time, please only one question per reporter. And we'll begin today with Sean Kirkby from Wisconsin Health News. Sean?
Thanks for holding this. Dr. Westergaard, how many doses or how many folks are vaccinated for monkeypox in the state so far of those 3,000 vials that have arrived? Thank you.
So nearly 600 doses were administered as of the close of business yesterday, and that number is rapidly increasing. Most of the doses, I think 300 were given last week, and then there were 200 just in the first 2 days of this week. So the places that are administering vaccine and scheduling appointments, those appointments are filling up fast. So we expect the number of doses to increase rapidly this week and into next week.
Thank you. Our next question belongs to Wyatt Bant from WKOW-TV in Madison. Wyatt? WKOW-TV? Okay, we'll move on then to Kaylin Schumacher from WBAY in Green Bay. Kaylin.
Hi, thanks so much for taking our questions today. I know that we've seen monkeypox start to pop up in a lot of areas in Wisconsin. Is there a particular part of the state that we're seeing the most infections?
So far, it's distributed in all regions of the state. It tracks with population so far. So in the central and southeast is when we've seen the most cases. We don't have the case or county by county counts available now, but we're happy to share those by request if you want to email our comms team. But I think the important message is that this is distributed nationally. I believe all states, if not very nearly all states, have reported cases, and many countries of the world. So there are no areas where I think the message that we're getting out about prevention and getting vaccinated if you're at high risk do not apply. I think all individuals who meet these criteria should ask their provider about whether getting vaccinated is right for them.
Thank you. Now to David Wahlberg from the Wisconsin State Journal. David.
Yeah, can you talk about how Wisconsin is incorporating the FDA announcement yesterday about using 1/5 of the dose? How will that impact distribution, availability? Will it cause problems in terms of the technique of being able to do that?
Yeah, great questions. And this is a new development, potentially a very high impact, positive development. And just for some background on this topic, the doses that were initially authorized for emergency use by the FDA were 0.5 milliliter subcutaneous injections. That means an injection under the skin. And that's of the 600 people that have received vaccine in the state so far, they've all been getting it that way. So in 2015, in preparation for future contingencies of potentially a smallpox outbreak, researchers studied this particular vaccine in several ways to know whether it could be stored for longer periods of time or whether the dose could be given in a lower dosage to be able to extend the doses. And based on that study, which is published and has been reviewed by the FDA determined yesterday that the alternate strategy of, rather than giving 0.5 milliliters under the skin, giving 0.1 milliliters inside the skin, or what we call an intradermal injection. If anyone has received a TB skin test for work, if you work in healthcare, it's sort of that method. So rather than going under the skin, the needle goes just inside the skin, causes a little bubble of fluid. So that strategy in this carefully conducted study showed that the response rate in terms of antibody generation was similar in both the traditional under the skin and into the skin. And in the case of an emergency, this strategy could be relied on to vaccinate 5 times as many people because it uses 1/5 of the volume. So now that we find ourselves in a public health emergency caused by a disease that's preventable by this vaccine and having short supply, the federal government took this action to expand the emergency use authorization of the Jynneos vaccine to be given in that way, in the intradermal. And the interim CDC clinical guidance is still saying that both are acceptable, the standard subcutaneous or under the skin, or the alternative intradermal. Obviously, we have more people who could benefit from vaccines that we have doses for. So the ability to stretch our vaccine that much farther is a great opportunity. So what we're doing for that is, number one, making sure that these new recommendations get distributed. Number two, we have to change our immunization registry so that the doses can get reported into our system so we can keep track of inventory and know who's getting what dose. That's important for our planning and in management of the response at the public health level. And number three, knowing that our partners who are administering vaccine have the equipment and have the training to administer the vaccine in this way. Our first message at this time is we don't want anyone to not get a vaccine because the pieces are not in place to give an intradermal vaccine. If a clinic is able to, if someone has an appointment for a clinic today and the clinic is not ready to do an intradermal vaccine, they should get the standard vaccine. But as soon as possible, in as many places as possible, we're going to be encouraging people to use the new technique. And we are looking into options to make sure that staff have the different syringes that can be used for intradermal administration, and are surveying all of our vaccinating partners to find out if there are any training or workforce needs. Intradermal injections is a technique that most nurses learn. They may not do it every day, but it's common enough, particularly because, as I mentioned, of tuberculosis testing, that it's common in most healthcare settings. So those are some of the things that we're doing to take advantage of this new opportunity to stretch our vaccine supply.
Okay, thank you. Now to Sarah Myers from the Beloit Daily News and Janesville Gazette. Sarah? And reminder, star 6. Sounds like you're there, Sarah. Go ahead. Star 6 will unmute your phone. Sarah Myers from the Janesville Gazette. Okay, we'll try to come back to you, Sarah. We'll go on then to Caroline Reinwald from WISN TV in Milwaukee. Caroline?
Hello, thank you so much for taking our questions today. You said that this obviously it's not an STI, though it is impacting certain members of the LGBTQ community, specifically being transmitted through sexual activity at a high rate. Doctor, can you explain why that is? I'm a little confused by that, why it's impacting significantly gay men and trans people like you were talking about, and it's not an STI. Can you kind of explain that a little bit thoroughly.
Sure. The way that I describe it is that it happens to be infecting this population first, and vaccines spread through networks of people that have close contact. So there's some of the earliest cases were associated with clusters of men who attended parties where there was sex occurring on site. I believe the initial wave of infection sort of happened to be in that community and has spread through those networks, and that's what we're seeing. This is still, as this virus, this infection does not move nearly as quickly as a respiratory virus for infection. So we may be in the very early phases of this. So it's really an issue of not difference in susceptibility. I think anyone with skin could be infected by this. It's where did the epidemic start and where is it moving? And that's a common theme in all communicable diseases. There's what epidemiologists study are what are the factors that determine why some groups are affected earlier and later. And those are generally complex answers. They have to do with geography, they have to do with behavior, they have to do with the frequency with infected and susceptible people come in contact with each other. So I think the best way to look at it is that it's two messages. One is that anyone who is susceptible or not vaccinated from this, if they had close contact with someone with infection, could develop monkeypox. And that's an important message, because when we find somebody, household contacts or other close contacts that are at risk should know how to take precautions and potentially get vaccinated or get post-exposure prophylaxis. And then the other is, at this moment, given what we've experienced so far, seems to be at the highest risk, and that is that group that you mentioned. So sexually active gay and bisexual men, that's where the epidemic has had the greatest impact. So we want to make sure that people in those communities know that they have been most heavily impacted so they can take prevention measures. So there's some infections that are really exclusively sexually transmitted. Gonorrhea and chlamydia, for example, are rarely transmitted other than through sex. This one is not an STD in that traditional sense. It happens to have been spreading through networks of sexually active gay and bisexual men, but it could infect anyone.
Okay, thank you. And we do find ourselves with some extra time today. We'll go back to Sarah Myers and then go around for follow-up questions afterwards. So once again, Sarah Myers from Beloit Daily News and the Janesville Gazette. Are you with us?
Hi, can you hear me now?
Yes, we can. Go ahead, please.
Okay, my question was just asked by the last reporter. Thank you.
Okay, well, then we'll go around for follow-up questions, and we'll begin with Sean Kirkby from Wisconsin Health News. Sean?
I'm good, thank you.
Okay. To Kaylin Schumacher from WBAY. Do you have a follow-up?
I'm great. Thanks anyways.
Okay. David Wahlberg, Wisconsin State Journal.
Sure, I have a couple. So of the 32 cases so far, are you able to share any information on age range, gender, how the cases were acquired, anything like that?
I'm not at this time. We are, cases get investigated and those data are collected in public, by local public health. That's something that we may release as part of an assessment or an evaluation, but it's not something we're prepared to share at this moment.
I can throw in another one. So people who might get a fifth of the dose in coming days or weeks, they may feel like they're getting less and they won't be as protected because of that. Can you address that concern that they might have?
Yes. Well, I think the first thing to know is that we are in a public health emergency. This vaccine has some data suggesting that it is effective and good data suggesting that it's safe, but it doesn't have a strong track record or has been studied nearly as much as, for example, COVID-19 vaccines, which we had clinical trials which showed a significant reduction in disease. So this is an unusual situation where we're going on indirect data that looks promising, but we don't have the large body of evidence that can allow us to quantify, for example, remember back in fall of 2020, we found 94% reduction in COVID infection with the Pfizer vaccine. So those kinds of large studies haven't been done, but the studies that have been done show that the vaccines are well tolerated. And when we measure the antibodies, and we probably all learned from talking about COVID-19 antibodies from vaccine, when we measure the level of antibodies that get generated in response to the vaccine, when they did that study comparing the intradermal dose or the low dose versus the standard under the skin or subcutaneous dose, they were shown to be equivalent. So the two strategies use not only a different dose, but also a different type of injection where it gets injected directly into the skin, which is, of course, where the virus enters the body and does and causes symptoms initially. When we looked at when the researchers looked at those data, they found no important difference. Both seem to stimulate the immune system in what we expect is a protective way. So that was a little long-winded. If I was going to say that to a patient, I would say, given the studies that we have, both vaccines, given the high dose or the low dose, seem to have the same beneficial effect on the immune system. And in the public health emergency, that information is enough for us to conclude that we can protect a lot more people by favoring the lower dose.
Thank you. And our apologies. There are some reporters who want to ask questions who were unfortunately left off our list. So we will call on them now. And we'll begin with Alex Mill from WisBusiness.com. Alex.
Hi, thank you for taking my question. I think I missed this at the start, but can you say again how many cases of monkeypox have been identified in the state?
32.
Thank you. Now to Eric Gunn from Wisconsin Examiner. Eric?
And if you said this earlier, I apologize. What are the kinds of, I think you referred to post-exposure protective care, preventive care that is being offered for people?
Yes. Yeah. So it's a big word we call it post-exposure prophylaxis, or PEP, which just eventually means giving something an intervention to prevent disease after exposure has happened. So that, by and large, that means giving a vaccine to someone who has had an exposure. So vaccines can be used and are more commonly used as pre-exposure prophylaxis, or PrEP we say, but before anyone that we know is exposed to the virus in this case. Post-exposure means even after someone, for example, was in the same household or had close skin-to-skin contact with someone that we know had monkeypox, post-exposure prophylaxis would be giving them the vaccine within the 14 days after the exposure happened, with the expectation that it would lower the risk of them developing the infection. Of course, with all infections, not everyone who's exposed to a pathogen, a bacteria or a virus, becomes sick with it. You know, there's some probability involved. Giving a vaccine after an exposure to the virus has happened in many diseases can lower that risk, lower that probability that someone will develop symptoms. And in that way, it becomes an important public health strategy. We lower the risk of a new person developing infection. We can stop that chain of transmission and potentially prevent future cases. So the use of vaccine is increasingly going to be for both of those scenarios. Post-exposure prophylaxis, meaning people that we know or are highly suspicious that they were exposed to the monkeypox virus, or traditional pre-exposure, which means these are people that are in the high-risk groups. They don't know that they've been exposed, but we want to reduce their risk going forward. They would also be given vaccine. CDC has asked us to prioritize that former category, post-exposure prophylaxis. That will likely be changing as the supply is clarified with the new dosing regimen. It's to the point where people can be getting for both post-exposure and pre-exposure. I hope I didn't confuse the matter, but it's those are essentially two strategies that we use vaccine in this instance.
Okay, thank you. Now to Hope Kerwin from Wisconsin Public Radio. Hope?
Hi. I am wondering, we're hearing more news about how colleges and universities are preparing for students to return back to campus to kind of protect them from seeing outbreaks there. So I'm wondering if you could speak to, if the state is offering any guidance to our colleges and universities, and also if there's any considerations for K-12 schools as well.
Yeah, that's a great question. Hope we have had meetings about that just earlier today. Also, it seems like many of the things that we are doing in response to the monkeypox outbreak are lessons that we've learned and strategies that we developed through COVID. So through our work with the COVID response, we made connection with a lot of college and universities, health, student health clinics and administrative leadership, and we are using those same communication channels to help them plan on campus and sharing the same sort of information about the disease, about who's at risk, about how to set up vaccination clinics. Less so with K through 12, that hasn't been as much of a stakeholder, but we similarly have good partnerships and good channels to communicate as needed. So we're available to consult with individual schools or universities as needed, and we'll likely be doing things like webinars and newsletters or information that we can distribute so the colleges and universities have the information they need.
Thank you. Now, Julia Lopez from WQOW-TV in Eau Claire. Julia?
Hi, thank you. I was just wondering about how the process of reporting cases goes and if there's any chance that cases could be underreported, as we've seen with COVID, with people testing at home or people just unaware that they are infected.
Yeah, thanks, Julia. That's another good question. So it's certainly possible that cases are going undetected by public health, meaning if people develop monkeypox related symptoms, if they don't seek care, if they don't get tested, then we have no way of counting them. But if they get tested, and there's a growing number of laboratories that can do the test to detect this virus, those laboratories are expected or required to report those results to state health department electronically for all those test results. So if a positive test comes back, but we're very confident that we have systems to capture them. But the point is, and as you mentioned in COVID, not all tests are not all cases and result in a positive test that gets reported. There is no home test so tests can only happen in a healthcare setting with a specimen sent to a specific lab. So I think the important message around this topic is that clinicians who suspect monkeypox should know how to do a test and where to send it. And we've been sharing a lot of information through the other channels that we've had to share new outbreak and technical guidance with healthcare organizations, and patients in the general public should also know, and we're making efforts for public communication as well, that if you have these symptoms and if you were exposed, you need to get tested, and testing involves going to a clinic where they can swab the lesions and send them to one of the labs that are doing this. So hopefully we're not missing any tests that have been, and I don't think we are, but the key is making sure that we don't miss cases because they're not showing up for medical care.
And our final question this afternoon belongs to Megan Messerly at Politico. Megan?
Hi, thanks for doing this. So I know you mentioned you all are in the process of surveying clinics to see whether they have the materials and staffing that they need to administer the vaccine intradermally. But has the state preventatively ordered more syringes since the announcement yesterday? I know some jurisdictions have said that they already have, anticipating that there could be some supply chain challenges like we experienced with COVID. What all are you doing on that front?
Yeah, we're investigating that now. I don't know that we've made any orders or purchase, but that's part of the information that we're gathering. I haven't heard that these types of syringes are particularly short supply, and so I strongly believe that the vaccines themselves would be the rate limiting step. So clinics and vaccinating partners may not have them on hand, but I don't know that there's a national shortage, for example. So we will see. But yeah, this is just this was news from yesterday, and we are trying to get all of our partners the information they need and hear from them what additional needs they have so they can implement this new strategy.
Okay, thank you. And with that, we will conclude today's media call. Our thanks to Dr. Westergaard and to all of you for participating. Additional questions can be sent to dhsmedia@dhs.wisconsin.gov. And please continue to monitor the DHS webpage for updates. Be safe and have a great afternoon.